Hi, everyone, and welcome to Conduent Healthy Communities Institute's webinar on building CHAs and CHIPs that build partnerships and engagement. My name is Jane Chai. I am a community health content expert here at HCI, and I'll be your moderator for today. So we are so glad that you can join us. We'll go ahead and kick off our webinar by covering a few logistics. So first, you've all joined this webinar as an attendee, so you're automatically muted for the duration of the webinar. But if you do have any questions during the presentation, please feel free to send them to all panelists via the chat box at the bottom right-hand corner of the WebEx screen. And I see you all are adding where you're from in there, so thank you so much. And it looks like we're able to use that chat box. We'll be reviewing those questions as they come in, and we'll try to answer as many questions as we can throughout the presentation. If not, we'll try to bring them up during the Q&A time at the end of the presentation. And lastly, a recording of today's presentation will be made available to you after the webinar. So now I have the privilege of introducing our presenters for today. First off, we have Eileen Aguilar, who is a public health consultant with HCI. Eileen brings over 15 years of public health experience to our team. Prior to joining HCI, Eileen was the Community Health Impact Analyst with the Maricopa County Department of Public Health, where she led the process of partnership and engagement with hospital systems, FQHCs, and other community organizations. In her role, Eileen works with public health. In her current role, Eileen works with public health departments, hospitals, and community organizations in completing team community health assessments and community health improvement plans. Karina Kelly is a public health consultant with HCI as well, and Karina brings a wealth of knowledge and over 16 years of experience to our team. She's worked with public health departments, hospitals, government agencies, and the Public Health Accreditation Board, or PHAB as you might know it. Karina is skilled at facilitating collaborative discussions and evaluating programs for quality and efficiency. I also want to introduce our Director of Consulting, Ashley Went. Ashley will be mostly behind the scenes during this webinar, reviewing and answering any questions in our chat. She may also join us on camera later on in the webinar during our Q&A session. Ashley brings over 15 years of public health experience, including domestic and international public health work. So for those of you who aren't familiar with who we are, Conduent Healthy Communities Institute, or HCI as we're known, has been a leader in the community health field for nearly 15 years. We've conducted hundreds of community health assessments and implementation strategies with partners across the country. We're also known for our nationally recognized platform that provides continuously updated health and social determinants of health data and acts as a hub for community health activities. The HCI team brings both a combination of advanced public health degrees and real-life experience in community health improvement. Some of the ways that our team can support health departments, especially those working toward accreditation, include support with their CHA and the CHIP, which we'll talk a lot about today. We also provide support for the access to healthcare assessment in Domain 7 and health department strategic planning and performance management. Now that we've introduced ourselves and some of what we do, we'll be turning off our videos in order to maximize the audio quality for the remainder of the presentation. So here are our objectives for today. We'll be covering ways to build CHAs and CHIPs that advance health equity with insights on health and social determinants of health, strengthen community partnerships to advance collective action, and meet standards for the Public Health Accreditation Board or other national frameworks. And with that, I'll pass this over to Karina, who will begin our presentation for today.
Thank you, Jane. We are excited to be here with you today and are ready to kick off this webinar. We like to start with looking at standards and frameworks. So as you are beginning to plan for your CHA and CHIP, it is important to understand what standards and frameworks there are to ensure you can meet the objectives. In this section, we will explore some of the standards and frameworks that are commonly used. We recognize that many health departments may be working towards PHAB accreditation or working with other community partners to complete joint assessments. In either scenario, it is important to understand which requirements are expected during the CHA and CHIP process, as well as what your partners may be following, such as IRS or HRSA requirements. Today's presentation will offer best practices for conducting assessments to meet those requirements. As you all may be aware, the 10 Essential Public Health Services Framework has been a guide for public health practice for the past 25 years. This framework recently changed to shift focus from solving community problems and evolved to include community engagement and partnerships that co-create solutions. Equity is now centered in every area of public health. With this change, PHAB has aligned its domains to reflect the new framework. If you are an organization looking to obtain PHAB accreditation, it's important to note that you will need to show documentation on how your department has incorporated equity and/or advanced health equity within your CHA and your CHIP, specifically looking at identifying ways equity is weaved in your programs and policies. Here are a few examples of assessment and planning framework models. These models are not all exhaustive, but reflect some of the most well-defined resources and frequently used models. As you may already know, framework are useful tools for improving community health. They may be used to help communities apply strategic thinking to prioritize public health issues and identify resources to address them. Assessment and planning frameworks do differ in many ways, such as types of data and recommended resources, or which community groups are engaged and how. Many of these frameworks can be blended, so it's important for your organization to identify which framework is best for your community. An important thing to note is that PHAB requirements focus on the process for developing the chip and not a specific model, although models may be referenced within the guidelines. This slide shows how HEI's standard process for assisting health departments through their CHA and CHIP. Our consultants, as Jane has mentioned, are experienced in working with multiple frameworks and are flexible with adjusting our process to ensure we meet various requirements. Looking at the planning and engaging stage, when setting up your community health assessment, it's important to engage your local community, your partners, civic leaders, and hospitals in your planning process. As we are moving to a more collaborative approach, aligning your assessments with your local hospitals can be better use of time and your resources. We typically will assist organizations with setting up these initial calls and meetings and/or creating an action register of items that need to be completed throughout the assessment process to keep us on track. Moving over to the collecting and analyzing your data, before you begin to collect and analyze data, it's important that you know your community and you know what questions, the right questions to ask to get the responses where you can make a measurable impact. Some of our clients and their communities are ready to explore topics of racism and discrimination directly, while others are still deciding how to do this. We understand that not every community is in the place to ask these types of questions, so we always begin with the goal of creating tools that will be most effective in a client's community. And with that, we have realigned our secondary data indicators to reflect Healthy People 2030 goals. We've also updated community feedback tools, including community survey, our focus groups, and key informant guides to amplify questions pertaining to social determinants of health, as well as health equity, looking at economy, food security, and housing security, just to name a few. Going into synthesizing data and prioritizing top health needs. When you're looking at synthesizing data, we review the overlapping health topics identified within the data categories we have collected. For most organizations, this may include community surveys or secondary data focus groups and/or key informant interviews. Mobilizing shared action has encouraged community engagement throughout this cycle, and communities we have worked with have appreciated being incorporated in the data collection and prioritization sessions to share their feedback on the data and also provide suggestions for implementation planning. And we'll have a couple examples on how collaboratives are doing this work. And lastly, looking at implementing and tracking. As we approach this implementation planning, we encourage health departments to look at this cycle as a continuous process of improvement. So we create template frameworks that can be easily modified and allow organizations to easily set and track outcomes and performance measures. We'll show you a few examples on how we assisted organizations through this process later in the presentation. Now I'm going to pass it over to Eileen so she can begin talking about how to advance health equity in your work.
Thank you, Karina. Now, we're going to explore how to advance health equity when building your CHA and CHIPs. When it comes to advancing and maintaining good health, it's critical to recognize that not everyone starts from the same place or has the same opportunities. So in order to advance health equity, you need to understand how communities are experiencing disparities. It's important that you have some data points that answer questions about health disparities and or inequities. So for example, looking at the disproportionate impact. So which communities are being disproportionately impacted by certain conditions? Also, the trends. Are things getting worse at a faster rate for certain groups? And looking at health inequities. What does the data tell us about the distribution of social and economic resources, which help us get to the root causes of health disparities? On this next slide, we're showing an image adapted from the Bay Area Health Inequities Initiative. We think this framework gives a good visual of community-level initiative indicators for health and social determinants of health that can really help you consider those questions that we just talked about. Oftentimes, data focuses on those indicators that are more downstream on the right-hand side of this spectrum, such as death and disease rates. But it's also important to have those data points shown in the middle about living conditions, such as overcrowded housing or access to parks. Beyond that, data should consider even more upstream indicators, such as differences in access to healthcare and unemployment rates, and those around social inequities, such as gender pay gap, poverty, and hate crimes. This is just an example of how you might use these frameworks for your data review. At HCI, we look across the spectrum of indicators as part of the assessment, as well as any breakdowns that we can find by gender, race, ethnicity, age groups, or neighborhood. And this helps us to priorities for the community health assessment with an equity lens. This data can come from publicly available sources such as CDC, American Community Survey, and local or state health departments. But you might find especially for data around disparities that are more granular, that are local community-based organizations or even academic institutions may also have some rich data that could be shared. We also caution against too much additional data collection until you've asked around about this. Many under-resourced communities are also over-researched. So as you conduct your assessments, we want you and encourage you to think very carefully on how to make sure that you don't add to that burden. Now that we've looked at having diverse sets of data indicators using an equity framework, let's talk about how to set ourselves up for success in our data analysis. So first, we want to think about breaking out data by class, gender, race, ethnicity, immigration status, or social orientation whenever possible. So for example, in our data analysis process, we included a review of breakout data where it's available to help us identify areas of disparities and for overall prioritization. We also want to think about how we want to intentionally develop community input tools. So for example, thinking about surveys and deciding on what types of surveys you would like to administer, whether it be an online survey or a hard copy survey, or even thinking about how to capture community voices from specific populations. So for example, groups like older adults, Hispanic Latino populations, or LGBTQ+. Working with existing partners who have established relationships with specific groups in the community can really help build their voices and bring them to the table and be part of your CHA and CHIP work. When thinking about what community survey questions to include, develop standard processing for analyzing data, and consider using or modifying a validated survey instrument or question. Key informant and focus group facilitation guides and questions are also important tools to consider as they provide an opportunity to add real-time community feedback to your process and really lift community voices that may not be represented in secondary data. And then lastly, looking to include a diverse set of community partners in the process. And just as a reminder that it's really important for us to continually ask who is not at the table. So now I'm going to pass it over to Karina, and she's going to go over a few examples of tools that were created using a health equity lens.
Yeah, so now let's look at how organizations are putting this into practice. Here's an example of a secondary data disparity analysis we created for a prioritization session. It shows the issue communities are experiencing and which group is most affected. In this slide, we explored how rising housing costs are affecting vulnerable populations. 60% of the community survey respondents in this community said there were not affordable places to live. The secondary data supported this point, showing an increase in median household rent over time, as you can see in the chart. Finally, we also layered data highlighting poverty differences by race and ethnicity for those 65 and older. Organizations can use these data analysis to engage with civic leaders to discuss housing situation and show data around communities most impacted. They can also meet with community organizations that are most affected and link residents to resources available. Here is another example. We utilized this example. It came from a community survey. This collaborative formatted their community survey and their focus group questions to assess community members' lived experiences around diversity, equity, and or inclusion. In this particular question, community respondents were asked in their day-to-day life, how often have any of the following things happened to them and why they believe they have experienced these. This collaborative is starting to dive into health equity and trying to understand the overall experiences of discrimination and to understand different groups' unique experiences and their perception of why they felt they were discriminated against. This chart is just an extension of the question on the last slide. We did a different analysis. The chart breaks down percentage of reported discrimination by different ways respondents identify themselves, as well as why they believe they experience this discrimination. Looking at example, in what ways did the Hispanic Latino community members report experiencing discrimination? And what did they believe was a main reason they were discriminated against? The highest level of discrimination they reported having experienced was being treated with less courtesy or respect than others. And they felt they had experienced this type of discrimination as well as others because of their ancestry or national origin, their gender, and or their race. So switching gears a little bit, we know that data can be a catalyst for improving community health and well-being. There have been a significant increase in the utilization of various social needs analytical tools and also predictive analytics to help organizations understand which communities are experiencing poor outcomes. Using indices like this gives us the ability to map data by city, zip code, census tract, or another regional grouping to help illustrate which communities may be more at risk. Again, we're looking at the opportunity to better understand where can help us focus our work, where there are opportunities to make the biggest impact. Some of the organizations we work with utilize HCI Social Need Index. These are examples of them to advance their health equity because they provide insights on health and social determinants of health. These analytical tools compare social economic need for every zip code in the United States. The Social Needs Index does this by combining 6 key demographic indicators into a single composite value, which is correlated with rates of preventable hospitalizations as well as premature deaths. For example, organizations may use the mental health index to visualize hyperlocal areas at greatest risk of poor mental health outcomes. They may also use it to justify and validate investments for prevention and early intervention, or they may use it to inform policies and interventions at the regional level. I will now pass it over to Eileen, who will begin speaking about partnerships and collaborations.
Thank you, Karina. So now let's jump into community partnerships and how strengthening them can be the most important part of your work. Cross-sector partnerships and collaborations are now standard and should be the center of how you are planning your CHA and CHIP work. Not to mention, it's also supported by PHAB standards. We also know that collaboration increases community efficacy in building health and well-being and advancing health equity. We can engage in active and ongoing strategic partnerships like creating collaborative activities. Some of the activities can include outreach efforts, joint events, or coordination of public messaging. In our work, we have seen many strong collaborations. For example, in response to the COVID-19 pandemic, partnerships were created to share data and disseminate information to the public. These partnerships continue to be strong and have learned as a result of the pandemic that working together made a positive change in their community. Partnering with organizations like federal entities, healthcare providers, and nonprofit hospitals who are also implementing their own assessments are all great examples of partnerships you can bring to the table to help complete your CHA and CHIP work. One of the first things that you'll probably decide is who to engage. As part of a readiness assessment or a resource inventory, you'll probably already identified the usual players. Here are some other questions to help you think about who else should be included. What individuals, organizations, or sectors must be engaged to ensure a successful process? Are there historically underrepresented groups who should be at the table? On the right-hand side of this slide, we've included just some of the organizations you might think of inviting. We really encourage you to think outside of the box about this. PHAB also requires that your CHA and CHIP should include engagement from various sectors, including at least 2 outside of public health and community members or organizations representing disproportionately affected populations. Once we've identified the partners to engage, another critical step is trust building. So as we get started, it's important to acknowledge the work that has already been done and the expertise that exists in the community. When you invite partners to the table, it's important that you treat them with equal partners with knowledge and expertise in their own right. Also, try to consider the partner's perspective as you invite them to the process. We know that we want to have an inclusive process that includes a broad range of partners, but what will they be getting out of it? How will this mission be uplifted by what you are trying to accomplish? And how will their mission be uplifted by what the collaborative is trying to accomplish? To gain trust, especially with new partners, you might first have to do some legwork. And this is where conducting a readiness assessment, as I mentioned before, or a resource inventory will be key. By doing this, you may uncover that there are some relationships that you might need to build or repair. So one of your first tasks will be likely to have one-on-one conversations to begin to build and or rebuild those partnerships or relationships. And lastly, just like any other relationship, building trust for your collaboration will take time and be an ongoing process. And again, just as a reminder, just like any other relationship, every step that you make together will help you build trust over the long term. As we begin building trust with our partners, we will also need to build a foundation to keep them engaged. How do we make sure that the partners are engaged throughout the whole process? So for instance, shared leadership. We know that health departments are most of the time the backbone organization for CHAs and CHIPs. It's important to have a decision-making approach by collaboration between all partners at the table. So for example, You may want to have a community partner co-chair for your CHA and CHIP steering committee or lead a work group. Shared values are also a way to engage partners and help to identify what is important in the CHA and CHIP process and how it's operationalized at meetings. Some organizations do this through an extended meeting, but you can also do this through a short survey. It can help provide clarity for your decision-making throughout your planning process. You can also think about developing a CHA and CHIP that demonstrates shared priorities and common goals. Make sure to dig in with your partners to learn what is already happening and where you can amplify each other's work. So for example, having a common agenda, some collaborators share priorities and common goals within their CHIP and or implementation strategy work. And then also ensuring that you have a shared implementation and evaluation plan. It's important for the partners to think about tracking common data for measurement and evaluation. When creating your CHIP work plan, make sure that you have buy-in from partners outside the health department to measure and monitor key activities that you have been contributing, not only to conducting activities, but also to track outcomes. This will spread the workload to make your relationship more accountable and partnership more accountable to each other and sustainable over the long term. Now let's look at some project examples that HCI helped to build cross-sector partnerships and collaboratives.
Thank you, Eileen, for setting the stage for this next portion. So here we would like to highlight some of the work that we have done with collaboratives involving health departments to show how some health departments have conducted this work to enhance collective action in their communities. Starting with Ventura County Community Health Improvement Collaborative, this is a formal charter-bound partnership. For their CHA and implementation strategy development, they worked with public health department, county hospitals, hospital systems, and other community organizations. We worked with the collaborative to have weekly and biweekly meetings to coordinate activities with smaller working groups. They also established an information exchange program to support community and organization communications, and also work together to spearhead and pilot a program and will share results at regular intervals. Looking at Calhoun County Collaborative, this is a multi-sector partnership of 6 partners, including a public health department, hospital systems, nonprofits, and a healthcare system. HCI worked with the collaborative to conduct weekly meetings for 5 months to help guide the CHA process. We also discussed best practices, monitored survey results, identified gaps, implemented marketing strategies, and identified trusted organizational leaders to assist with survey distribution. HCI worked with the collaborative to conduct multiple public prioritization sessions to ensure inclusivity and increase participation across the county in understanding the community's needs. Currently, HCI is providing technical support to showcase CHA secondary and primary data to leadership groups to help with implementation strategy plans, as well as assisting with establishment of a steering committee for continued CHIP work. The All for Health Collaborative created a charter that provided overall direction, structure, and clarity on goals and objectives. Each organization had strong community partnerships and relationships that supported the community health assessment. They helped out with promotion and dissemination of surveys for communities that have historically underrepresentation in data collection. They also created working groups for each phase of the community assessment process and conducted weekly meetings to analyze community responses by zip code to ensure equal distribution. We assisted with facilitation of focus group discussions with disproportionately impacted communities and demographics. Questions were developed and analyzed with the intent to understand how aspects of an individual's race, gender, age, ethnicity, and/or sexual orientation affected access and treatment of care. The collaborative also invited city officials, hospital and department leaders, as well as community organizations and residents to be a part of the prioritization process, and they incorporated their feedback in the implementation planning. Now that we have spoken about specific collaborative examples, I'd like to share some insights about how collaboratives that we've worked with have been able to build, implement, and sustain a collaborative CHA and CHIP effort. Starting with assess readiness, I know Eileen mentioned this before, but one of the first considerations for effective collaborative for their CHA and CHIPs is to assess whether the collaborative is ready for this effort. There is no transformation without collaboration and no collaboration without this readiness. Conducting a readiness assessment can help you identify where you have resources to get started and areas that you may need to work on before getting started. Next, you need to look at building shared spaces. Another consideration is whether you will have the ability to build these shared spaces. For instance, does your collaborative have a shared vision and a unique purpose? As Eileen mentioned earlier, building trust and mutual respect is an important factor in sustaining and growing your relationships, which are needed to gain buy-in. Part of the shared effort will be about aligning timelines. While health departments may be on a 5-year cycle for their CHA and CHIPs, many hospitals may be on a 3-year cycle. Many of these collaboratives we work with have aligned their timelines so that health departments work on a 3-year timeline. Working on the CHA and CHIP can build a shared space for collaboration on a number of topics. Next, look at aligning implementation strategies. But it's not just about aligning timelines, it's also about members sharing a stake in both the process and the outcomes so that they see the value in the collaborative and support the vision and the mission of its work. When working with our clients, we have typically utilized a logic model to assess resources such as funding or engaging influential champions that are needed to implement specific activities or programs. Some questions we ask are, what level of change are we aiming to make within the community? Short, medium, or long-term change? Whose support do we need to make the long-term investments to achieve success? And what data are we using to set the agenda and using to measure and make improvements over time? The answer to these questions help inform a plan with goals, objectives, and strategies that involve different partners. This helps all partners take accountability and helps to align resources that put community health outcomes ahead of institutions, and also helps providers get out of the silo mentality. And lastly, look at measuring what matters. For many organizations that we work with, setting attainable and measurable collaborative goals and objectives can be a challenge. The key here is to ensure that your group has engaged tracking progress and that they are using data and information to adjust and or make changes. Some questions you may want to answer include, how are you changing policies? How are you changing culture or norms and or systems? What impact are we having? Your indicators of success would be evidence of progress and impact that can be measured. For some organizations, this may be a time where you set baselines on year one, and then you adjust your process measure targets each year or as needed. So I know we went through a lot of information today, and we thank you for allowing us to share our knowledge and experience of how to build CHAs and CHIPs that advance health equity, how they strengthen community partnerships and meet various frameworks and standards. Just to give a recap, we discussed the differences in various frameworks and also discussed how PHAB has aligned their 2022 standards with the 10 essential public health services. We have also explained our process for assessing organizations through the community health assessment planning cycle. Then we discussed ways to advance health equity by looking at community disparities, trends, inequities, and utilizing social need indices to provide insights on health and social determinants of health. We went through a few examples of how organizations are using disparity analysis, and how they are framing questions to start understanding community lived experiences around diversity, equity, and inclusion. And lastly, we explained the importance of strengthening community partnerships and how to set the stage for continued engagement and cross-sector partnerships. Then we looked at a few examples of collaborative work and how organizations are utilizing community dashboards to share the data. And now I want to turn it back over to Jane to finish wrapping up this webinar.
Thanks so much, Karina. That actually concludes our presentation and will lead us to the discussion portion of the webinar. We saw a lot of great questions come in. So please feel free to ask them in chat to all panelists or to everyone. And for this part of the webinar, we'll go ahead and turn our cameras back on. And we can stop sharing screen so we can just have a conversation. We did have some questions. Let's see, the first one, maybe Karina, since you just finished, I'll direct this one to you. We've had trouble incorporating health equity into our chip. Do you have any examples you can share of where you've worked on something like this?
Yeah, that's definitely a great question, and I'm glad organizations are looking at ways to start incorporating health equity into chip work and start work is by one of the things that we do is work closely with health departments and organizations to identify inequities that affect people's ability to live healthy lives. For example, we mentioned a little bit earlier using tools like the readiness assessment to determine if the collaborative or if the partnership is ready to address these health equities. And I think that's key here. HCI also references other resources. Some of the frameworks and standards that we mentioned earlier on in this presentation also help frame health departments' chips around health equity. So I hope this answered your question.
Thanks, Karina. I have another question, and this kind of tags on to the one that was just asked about frameworks. And maybe Eileen, if you wouldn't mind, is there a framework that you recommend or prefer using when you're doing the CHA on the chip?
Yeah, thanks, Jane, and thank you for the question. It's a great question and often a question when we meet with our clients. That's definitely something that we discuss with them. And we don't use a specific framework for our planning model, but we do recommend commonly used planning models and frameworks and tools that are definitely in the nationally recognized public health organization, CDC, those models and frameworks that are data driven. And then, of course, we use sound research and analytical tools to help determine what best model or framework to use for our clients and their community as well.
Thanks, Eileen. This is another one. This one came in a little while ago. Have you worked with communities that have a collaborative approach with hospitals that are addressing the CHA on the chip and the CHNA on the same cycle and efforts? Working together, meaning establishing a joint work plan from the beginning. I know, Karina, you covered a bit of this. I think that many of the collaboratives that you shared had both hospitals and health departments. But maybe Ashley Went, if you wouldn't mind sharing, maybe elaborating if there was anything that we wanted to add to this.
Sure, happy to, Jane, and I apologize for not being able to share my video, but I would say the majority of the clients that we have are collaboratives that include hospitals, hospital systems, health departments, and community organizations. And we really encourage them to come together as early on in the process as possible, both to have discussions around how they can align those timelines. As Karina mentioned earlier, if you're working to meet your PHAB requirements, that's a 5-year cycle typically, and for IRS requirements for our nonprofit hospital systems, that's typically a 3-year cycle. So that's where a lot of folks tend to see their first challenge. And again, as Karina mentioned, it's usually with the health department making the concession that they will go through this process with their nonprofit hospital partners on a 3-year cycle. And that may mean that on the off cycle, there may be work that still goes on, but it may be less intensive than an active cycle. I also think some lessons learned from working with collaboratives is again, coming together early and often to identify and be transparent and open about your individual needs that need to be met through these processes. Hospitals have very specific needs as far as their assessment and work development, as do our health department partners. And so it really helps to ensure that as we're putting a work plan together, that all those are incorporated so that we don't get halfway through a process and realize that something very important has been left out. I think it's also very helpful to be intentional about how the prioritized health needs will be identified and utilized. Will each of the partners be using all of the prioritized health needs that are identified? Will there be collective needs that are identified and then each partner taking those to their individual processes? And that will also influence how you may approach a collaborative SHIP or implementation strategy development, if there will be shared collaborative goals and objectives that everyone is working together on, or if everyone is kind of individually contributing to a work plan, but really doing that work more independently. And I think that is something that we are having more conversations with our clients as of late, as capacity really becomes a question. So just being, again, very transparent and open and realistic as we come together to do this work. But the benefits really pay off. Again, we're not over analyzing the communities. We're able to coalesce around this work and break out of our silos and really work together to make more direct community impact and improve community health. And it can also be very cost effective. So really great question, Jane. I don't know if you'd add anything else.
No, I think you covered it. We have a little bit of time left and a couple of really good questions that just came in. So I'm going to go ahead and pose this to the group. What's an efficient and effective way of surveying our community? We did focus groups the last cycle and we were able to gain so much insight and depth of understanding, but it was also very time consuming and lots of work. I'm considering a mode that gains depth of insight, but also is more manageable for a small team. I know we work with health departments a lot on this, so and hospitals a lot on this. So I'm hoping someone on our team can take this. Maybe Ashley, if you wanted to say anything about this, what is a way of surveying that can be less intensive for a small team?
Sure. And I think that's where we typically approach community surveying as one of the tools and one of the data sources that we build into our process for our clients, in addition to the secondary data, in addition to any qualitative data, whether that be from key informant interviews or things like focus groups. But we really have started to rely more on digitally distributed community surveys. Really being intentional on how many questions you build into that survey can be very important. Again, you've got a really robust secondary set of data that you're building in from lots of really strong national, state, local sources. So we really don't need to reinvent the wheel by making a 100 question or 150 question survey. That's very time consuming, and we've really seen participation drop across the survey when it's that involved. So we typically encourage our clients to limit question length in a survey to 40, 45 questions. That typically maxes out about 10 minutes for someone to participate in. We also really encourage you to think about utilizing skip logic, and that's something that you can really easily incorporate if you're approaching that as a digital survey. But again, you also have the option of still having paper surveys if and when you need that to reach out to very specific populations. So our clients that rely on digital surveys, we may also still develop paper surveys for distribution for the 65 and older population, or a homeless population, or a veterans population, or our Spanish speaking population. And again, thinking about accessibility, understanding what languages are predominantly being used, especially with your hospitals. That's a good resource. They know what language lines they're using. So outside of Spanish, what other languages may we think about translating our tools into? And so I think just making that tool more manageable and approachable is an effective way to build that tool and get effective data back in that manner.
Yeah, thanks, Ashley. And I'll add that if you have hospitals or academic institutions or community-based organizations, I think Karina mentioned this earlier, but making sure to ask them if they've done any surveying recently, because oftentimes they have, and they might be willing to share some of those insights so you don't have to go out and do it again. I see we're at time, but we have a really great question. I'm just going to quickly maybe respond to it and then close us out. We could share, Andrea, maybe we can go ahead and share our information as we're closing out. The last question we're able to take, our health department has a challenge of trying to get other partners to take leadership roles for the CHIP work groups. Do you have any advice? I would say, consider, one of the things is to consider what activities or work groups already exist, and maybe trying to work with those partners to see if you can, I wouldn't say co-op, but like collaborate with them so that we're not creating new work groups or we're not creating new work for folks, because I think that's where folks are often challenged. They're stretched very thin. So how can we leverage the work that folks are already doing or the partnerships that already exist? To make sure that we're not overtaxing the system. But we've put up our information because we want to be really conscious of everyone's time. And so please, if you do have any additional questions, I'm sorry we couldn't get to all of them today. Please feel free to email us and we'll get back to you. For our current clients, please feel free to teach or reach out to your account manager or project manager if you have any questions after today's webinar. So thank you again, everyone, for joining us today, and that will conclude our presentation. Have a great rest of your day.